The Elderly Depression Solution, CBT and REBT Unveiled. Introduction. Major Depressive Disorder, MDD, remains a pervasive mental health concern among the elderly, demanding a systematic exploration of contributing factors and evidence-based treatment approaches. This video considers the intricate interplay of biological, psychosocial, and environmental factors contributing to MDD in the elderly population, with a primary focus on established second-wave behavioral models, particularly cognitive behavioral therapy, CBT, and Rational Emotive Behavior Therapy, REBT. This video aims to equip psychotherapists and interested individuals with a comprehensive understanding of the challenges posed by depression in the elderly and the application of targeted therapeutic interventions. Let's consider the biological, psychosocial, and environmental contributing factors. 1. Biological factors. The biological underpinnings of MDD in the elderly involve neurobiological changes and genetic predispositions. An understanding of neurotransmitter imbalances, alterations in neural circuits, and the influence of hereditary factors is crucial for tailoring effective interventions for elderly patients experiencing depressive symptoms. At an even more basic level would be evolutionary-based propensities to developing depression in this population due to aging and an increased perception of environmental threats to self and comfort. This increase in perception of overwhelming threat may be due in part to a growing sense of vulnerability to environmental challenges and decreased resources, often due to isolation and loneliness. 2. Psychosocial factors. Elderly individuals often grapple with psychosocial challenges, including social isolation, the loss of loved ones, chronic medical conditions, and cognitive decline. These factors intertwine, creating a complex web that could contribute to the development of depressive symptoms. An exploration of psychosocial dynamics is essential for clinicians seeking to better understand the major contributing factors contributing to depression in this demographic. 3. Environmental factors. Socioeconomic status, living conditions, and access to health care significantly impact the manifestation and persistence of MDD in the elderly. Addressing these environmental factors is vital in formulating a holistic approach that considers the broader context of an individual's life. 4. Evidence-based treatment models. A. Pharmacotherapy. Antidepressant medications continue to be a cornerstone in treating MDD, with careful consideration required for potential side effects and interactions in the elderly. A tailored pharmacotherapeutic approach, if warranted, is essential for optimizing treatment outcomes. B. Cognitive behavioral therapy, CBT. CBT, rooted in the second-wave behavioral models, addresses distorted thought patterns in the form of inferences and beliefs and behaviors contributing to MDD. By implementing cognitive restructuring and behavior modification, CBT provides a structured and goal-oriented approach that aligns with the unique needs of elderly individuals. C. Rational Emotive Behavior Therapy, REBT. REBT, a precursor to CBT, focuses on identifying and challenging irrational or unhelpful inferences and beliefs that contribute to emotional distress. By promoting cognitive and emotional flexibility and engaging in the process of identifying dysfunctional beliefs, challenging them, and replacing them with functional, adaptive cognitions, REBT offers elderly patients a powerful framework for reframing negative thought patterns and fostering ongoing resilience. 5. Case studies and clinical applications. Illustrative case studies provide practical insights into the application of CBT and REBT in elderly patients. These examples showcase the adaptability of these models to diverse clinical scenarios, emphasizing their relevance in addressing the unique challenges posed by MDD in the elderly. 6. Challenges and considerations. Tailoring treatments to the elderly population requires a nuanced understanding of the multifaceted age-related considerations. Treatment adherence, potential interactions with other medications, and the management of comorbid medical conditions are paramount in ensuring the success of therapeutic interventions. Case study and clinical applications. Let's now turn to a hypothetical case study that may help provide practical insights into the application of CBT and REBT in an elderly client. This case showcases the adaptability of these models to diverse clinical scenarios, emphasizing their relevance in addressing the unique challenges posed by MDD and the elderly and tailoring them to the unique needs of the specific elderly individual client. Case study: Mrs. Thompson. Background: Mrs. Thompson, a 75-year-old widow, seeks therapy following the recent loss of her husband. Her history reveals a close-knit family, but with her children living in different states, she experiences feelings of isolation. Mrs. Thompson has a medical history of hypertension and mild arthritis, and she has recently been diagnosed with mild cognitive impairment. The loss of her husband has exacerbated feelings of loneliness and contributed to a pervasive sense of hopelessness. Presenting symptoms: during the initial therapy session, Mrs. Thompson presents with symptoms indicative of major depressive disorder. She describes persistent feelings of sadness, sleep disturbances, loss of appetite, and a lack of motivation to engage in activities she once enjoyed. Mrs. Thompson expresses overwhelming guilt about not being a better caregiver to her husband during his illness, contributing to a negative self-perception and a sense of worthlessness. Her rumination on her perceived failure to attend adequately to her ill husband intensifies her depression. Treatment plan. Cognitive interventions. Identification of irrational beliefs. Mrs. Thompson holds irrational beliefs in the form of demandingness, frustration, intolerance, awfulizing, and global negative rating. She demands that she should have been a perfect caregiver and holds the irrational and dysfunctional belief that it's awful that she wasn't. Additionally, she globally rates herself as completely worthless due to perceived shortcomings. Cognitive restructuring. Work collaboratively to challenge these irrational beliefs. Using thought records, address demandingness by exploring the idea that perfection in caregiving is an unrealistic standard that causes depression. Challenge awfulizing by examining the differences between something being awful in terms of negating all meaning, purpose, and potential future happiness, and as in the alternative belief that falling short of perfection is normal and consistent with the fallibility of being a human, even a very caring human. Introduce more realistic self-forgiving self-talk to counteract and replace global negative self-ratings with unconditional self-acceptance. Behavioral interventions. Activity scheduling. Develop an activity schedule to reintroduce enjoyable and meaningful activities into Mrs. Thompson's routine. Gradually increase engagement in social activities, fostering connections with friends or joining community groups to address feelings of isolation. Combine this behavioral intervention with cognitive restructuring of beliefs that would impede such increasing engagement. Beliefs such as, no one will care, reaching out to family and friends won't help, nothing I do will bring my husband back, so I am doomed to loneliness. Behavioral activation. Implement behavioral activation techniques to enhance motivation. Break down larger tasks into smaller, manageable steps and establish a reward system to reinforce positive behaviors. This approach helps Mrs. Thompson regain a sense of accomplishment and purpose. Emotive interventions. Rational emotive imagery. Use this form of imagery to vividly imagine and challenge irrational beliefs. Guide Mrs. Thompson through scenarios where she confronts guilt and unworthiness, encouraging her to dispute and replace the associated irrational and dysfunctional thoughts with more rational and helpful alternatives. B. Disputing irrational beliefs. Facilitate the disputing of irrational beliefs using the ABC model. Help Mrs. Thompson recognize the activating event. A. Explore her beliefs. B. And encourage her to dispute and change these beliefs to influence consequences. C. This process fosters emotional regulation and resilience. Progress and adjustments. Monitor Mrs. Thompson's progress through ongoing assessments of mood, behavior, and thought patterns. Collaboratively adjust the treatment plan as needed, ensuring a tailored and responsive approach to her evolving needs. Encourage Mrs. Thompson to maintain a therapeutic journal to track her emotional experiences, challenges, and victories. This detailed treatment plan, integrating cognitive, behavioral, and emotive interventions from both CBT and REBT, addresses Mrs. Thompson's unique challenges in the context of major depressive disorder. By identifying and disputing demanding, awfulizing, and globally negative beliefs, the plan aims to empower Mrs. Thompson with effective coping mechanisms and promote a positive shift in her emotional well-being. In conclusion, addressing major depressive disorder in the elderly necessitates a comprehensive understanding of contributing factors and the application of evidence-based treatment models. The focused exploration of CBT and REBT, rooted in first and second-wave behavioral models, provides a targeted and often effective approach. By delving into these established therapeutic frameworks, we may contribute to a deeper comprehension of depression in the elderly and advocate for tailored interventions that enhance mental health outcomes in this vulnerable population. Disclaimer: this video is intended for educational purposes only and should not be considered a substitute for professional advice or treatment. The information presented is based on general knowledge and is not intended to provide legal, medical, or psychological advice. Viewers are encouraged to consult with qualified professionals for personalized guidance tailored to their specific circumstances. If you believe you may benefit from legal, medical, or psychological assistance, it is crucial to seek the expertise of trained and licensed professionals. The content in this video is not a replacement for individualized consultation with a qualified practitioner, and we do not endorse or guarantee the accuracy, completeness, or appropriateness of the information shared.